Welcome everyone. Thank you for joining us this evening. So this is a little bit of a mixed bag that we're going to talk about. You don't often have a talk where you're talking about three different cancers all at once, but we wanted to give you a little bit of an overview about what you need to know about the three most common gynecologic cancers: endometrial cancer, ovarian cancer, and cervical cancer. So we're going to break it down into little snippets about each cancer, and hopefully you will find it helpful. And I think the most important thing that you want to get out of today's talk is information that will empower you to be a better patient advocate. It's right now during the COVID-19 pandemic, there's so many symptoms that have gone unrecognized or postponed because of COVID, because of fear of going to doctors, and we hear that. But it's important to know what to look for so that you know when it's okay to watch something and when you need to get medical attention. So what I'm going to do is I'm going to talk about endometrial cancer, and then Dr. Podolski will talk about ovarian and cervical cancer, and we will take any questions that you guys have at the end of the talk. So just to introduce myself again, I am Eleonora Teplinsky. I am the head of breast and GYN medical oncology at Valley Mount Sinai Comprehensive Cancer Care. For those of you who don't know, we are located at the Lookout Pavilion in Paramus, New Jersey. And I urge all of you, if you are on social media, to follow along with me. On my Instagram handle is Dr. Teplinsky. You can find me on Facebook and Twitter as well. And I do a lot of patient education on there. And it's a great way to interact with me, out of the office as well. So with that, let's talk about the outline for today's talk. So number one, we're going to talk about what endometrial cancer is, what are the risk factors, screening for endometrial cancer, and if that's something you can even do, the symptoms, how it's diagnosed, and basic treatment. On the bottom, you'll see a picture of some members of our team. This was for a virtual walk that we did. We had to adapt some things during COVID, and it was a great success. We did that in October. And behind the team, you'll see where we're located. That's our building. That's the Lookout Pavilion right off Route 17, and where it's right across the street from where the new hospital is being built. So basic information about uterine cancer. So you'll notice that I've used uterine and endometrial cancer interchangeably. And that's because endometrial cancer is a cancer of the uterine lining. So we are using those terms interchangeably. It develops in 1% to 2% of women in the United States. It is the fourth most common cancer in women and the most common gynecologic malignancy. And we most often find it between the ages of 60 and 70 years old, but it can be later or earlier. And majority of endometrial cancers are diagnosed at an early stage. And when diagnosed at an early stage, typically stage 1, your 5-year overall survival is greater than 90%. So these cancers have a really good prognosis. Fantastic. Unfortunately, some of the cancers diagnosed at a later stage don't have as great of a prognosis, which is why research and clinical trials and drug development is so important. And we have a number of gynecologic clinical trials at Valley designed to improve survival for our patients. There are 2 types of endometrial cancer. So type 1, most common type, it's also known as endometrioid type. And these do tend to have a better prognosis. They present most often with abnormal uterine bleeding, meaning if you are postmenopausal, anytime you see blood, that is not normal and needs to be worked up. If you're premenopausal, that's typically going to be bleeding in between your period, a much longer menstrual period than you're used to, breakthrough bleeding, that kind of thing. And then type 2, these are about 10 to 20% of all endometrial cancers, and these tend to be serous, clear cell, and some others. And those, unfortunately, don't have as great of a prognosis. You may be wondering, well, how do I know what kind of cancer I have? And this is information you will find on a pathology report. So once someone has treatment or surgery or a biopsy to diagnose endometrial cancer, the pathology report will actually specify what kind of cancer it is. And up here, you'll see I have the graphic of, I have the ovaries, the fallopian tubes, and then the big thing in the middle is the uterus, obviously going down into the cervix and vagina. And you can see that mass of cells there, and that's where uterine cancer is going to typically develop. It's important to know who is at risk. So I mentioned that, it's 1 to 2% of all females or women, but who is at higher risk, right? Why do some people get it and others don't? So here are the risk factors: increasing age, unopposed estrogen therapy, tamoxifen, which is taken for breast cancer, late menopause or not having children, also known as nulliparity. And those are risk factors because the later you go into menopause, or if you don't have children, that is more estrogen that you have in your body, again, fitting with that unopposed estrogen therapy part. Polycystic ovarian syndrome, obesity, diabetes, a family history of uterine, ovarian, breast, or colon cancer, and then certain genetic syndromes. And Lynch syndrome or Cowden syndrome are the two most common ones, and we'll touch a little bit more about that later on. Knowing what the risk factors are, people who may be at higher risk for uterine cancer will say, well, how do I get screened? How do I find this early? And so, unfortunately, there's no good non-invasive test for endometrial cancer. It's not like breast cancer where we can do a mammogram or a Pap smear for cervical or a colonoscopy. And there's really routine screening with ultrasounds or endometrial biopsies or Pap smears is not recommended. I will stop here and say that Pap smears are used for cervical cancer screening. Sometimes a routine Pap smear will pick up something that signifies uterine, but it's not, you don't use the Pap smear to look for uterine cancer. We also, for patients with breast cancer on tamoxifen, because there is a higher risk of uterine cancer, this always comes up, should I be screened? And the answer really is no. Sometimes the gynecologists do want to do pelvic ultrasounds, and that's fine, but we certainly don't recommend any routine biopsies in the absence of symptoms. So the good news is that 75 to 90% of patients are symptomatic, and meaning they will present with the symptoms such as abnormal uterine bleeding. So this allows us to pick it up at its very early stages. What's different about uterine cancer when compared to ovarian cancer is that ovarian cancer, by the time you have symptoms, it's typically a stage 3 or stage 4 diagnosis, and the prognosis is not as good. Uterine cancer, when you have symptoms, you're going to have most often a stage 1 cancer with a great prognosis. Now, of course, if there was a better test so we can pick it up before it developed, that would be ideal, but we don't have that at this time. And so the most important thing is for patients and consumers and everyone to be educated about what is the risk of uterine cancer. So knowing your risk is important. Are you low risk? Are you high risk? Knowing what symptoms to watch out for, and then knowing when to call your doctor. So I said, abnormal uterine bleeding, never normal. So that's not something that you want to wait on. Let me touch briefly on Lynch syndrome. So Lynch syndrome is a genetic syndrome that runs in families. The most common cancer associated with Lynch syndrome is colon cancer. The next most common is endometrial cancer. There are others, breast, ovarian, GI cancers, and others, but these two are the most common. And so remember I said 1 to 2% of women in the general population will have endometrial cancer. Lynch syndrome, it is 12 to 54%, so it's significantly higher. And for these patients, we actually do recommend screening because we know their risk is so much higher, and that is going to be a endometrial biopsy every year, starting at age 30 to 35, or if there are any Lynch-associated cancers in the family, so let's say your dad was diagnosed with colon cancer at age 40, it would be 5 to 10 years prior to the earliest age of any cancer in the family. And once people are done having children or are ready, then a risk-reducing hysterectomy, meaning taking the uterus out and often the ovaries and the fallopian tubes as well, that depends, is recommended. And obviously for symptomatic patients, we would do a biopsy. We don't wait on those things. Let's briefly touch on the symptoms and then we'll talk about diagnosis. So I mentioned abnormal uterine bleeding, a couple of other ways that we get concerned about uterine cancer. Abnormal Pap smears. Again, remember, Pap smears are not to look for that, but they can be helpful. Sometimes people will have imaging for another reason, let's say to look for a, let's say they thought there's abdominal pain, they're looking for an appendix, an enlarged appendix or something like that, then they will find it that way. In early cancer, the pelvic exam is usually normal. So you may be having abnormal bleeding and go to your gynecologist and have a normal pelvic exam. That's very common. In advanced cancer, we may see that the uterus is enlarged or fixed to the pelvic wall. Most often, the blood work will be normal unless you're having a lot of bleeding, which is making you anemic. We usually don't pick anything up that way. One of the things that can be helpful in postmenopausal women is increased endometrial thickness, meaning the lining of the uterus looks thicker. So that can be a tool that there's something there that we want to work up. Most important thing is to not ignore symptoms. So what should you do if you suspect a problem? The first step is always going to be an endometrial biopsy. This is done in the office by the gynecologist. Easy procedure, a little bit uncomfortable, but again, an in-office procedure. If the diagnosis is made on the biopsy, then you are referred to a gynecologic oncologist for treatment and surgery and things like that. However, sometimes the endometrial biopsy can be negative. Now, it could be negative because it truly is negative, or it can be negative meaning that there is a cancer there that we haven't picked up yet. And this is where it's really important to know what your level of suspicion is. So I'll give you an example. A lot of times people who are postmenopausal will have very significant vaginal dryness, and the tissues are very thin of the vagina and they're very dry, and so they're prone to bleeding. So some people may have very mild bleeding. And if you suspect that, you have a normal exam, you have a normal pelvic ultrasound, you have a negative endometrial biopsy, and it's a tiny amount of bleeding, you may say, all right, I'm pretty sure that's from vaginal dryness. We'll keep monitoring it, but we can stop right now. Versus you have someone that's having a lot of bleeding, maybe an abnormal pelvic ultrasound or abnormal exam, and you're concerned. So for that, you're not going to stop at a negative biopsy. The next step is a procedure called a hysteroscopy, which is a small tube that's inserted into the vagina to examine the cervix and the inside of the uterus, and then a D&C, or a dilation and curettage, which is performed, which is essentially scraping of the uterus to get a bigger sample. Most important point I can make is that if there's negative results with persistent symptoms, don't give up, keep looking. And the approach to treatment is this. So the first and foremost thing is surgery. Usually the uterus is taken out very often with the fallopian tubes and ovaries as well, cervix, some lymph nodes, and a lot of that will depend on what the biopsy shows and whether or not we think it's a bigger cancer or early cancer, that kind of thing. The goal is always a minimally invasive approach using either laparoscopic surgery or robotic surgery, minimal invasions, very easier recovery. But some cancers, more advanced disease, will require a bigger and open surgery, bigger incisions. After that, so the surgery is typically performed by a GYN or gynecologic oncologist. You will have the surgery, you meet with the gynecologic oncologist to review the pathology. And after that, depending on what we find in the pathology, depending on the stage, which I'll show you in a second, depending on certain prognostic features in the pathology report, some patients will require chemotherapy and or radiation to decrease the risk of recurrence. When I think about cancer treatment, for any cancer, I break it down into two categories. Our first category always is, well, how do we get rid of the cancer? We found it, we'd like it out, so we're going to get rid of it with surgery. How do we decrease the risk of it coming back? And that's going to be your chemotherapy and your radiation. And just very quickly, I will show you the different stages. So stage one, and this is the top left here, it is confined to the uterus. Stage two, it starts going outside of the uterus into the cervix. Stage three, the cancer is spread now either to the ovaries, to the vagina, to the surrounding lymph nodes in the area. And then stage four, it's going to spread outside of the pelvic tissues, to the bladder, to the bowel, to the liver, and so forth. And I will end with this. One of the big things that I talk to my patients about is you really can't prevent uterine cancer. You really can't prevent most cancers. Certainly with colonoscopy, we can identify early things, but in general, you can't prevent cancer, but you can take action to lower your risk. And if you know me, I am a huge advocate for health and wellness and using diet and exercise for cancer risk reduction. And I'm going to share with you what the American Cancer Society recommends for risk reduction of endometrial cancer. And these are being at a healthy weight, and that includes weight loss if there is excess body fat, reducing the amount of time that you're sedentary. In addition to that, so in addition to being active and moving throughout the day, regular, moderate to vigorous physical activity is recommended. And this is your 30 minutes, 5 days a week. And then eating a diet with a low glycemic load. Remember, diabetes increases your risk for uterine cancer. So when we talk about low glycemic load, we're talking about avoiding sweets, avoiding high sugar, low fiber foods, and sweetened beverages. And, a lot of beverages we don't realize have added sugar to them. So really being mindful of that. And with that, I will end and I will turn it over to Dr. Podolski, but I look forward to answering any questions you guys have at the end of her talk. All right, I'm going to stop sharing my screen. And Amanda, you are on. I'm going to stop my video now.
Okay. Sorry, give me 1 second. Okay, hopefully you guys can see the slides okay. So as Dr. Teplinsky just said, she obviously just spoke all about endometrial cancer, and now we're going to transition to talking about cervical cancer and ovarian cancer with a relatively similar outline to what she did, with a little less emphasis on treatment and kind of the approach to management. So we'll start with cervical cancer. This image just basically shows, clearly this is, as she showed earlier, here's your uterus, your vagina, and the cervix is the area right between. And with cervical cancer, you'll have abnormal growth of cells there. So just some helpful stats. Cervical cancer is the third most common gynecologic cancer and cause of death amongst gynecologic cancers in the US. So, the other two that we're going to be speaking about are the more prevalent or more common causes of death as well from gynecologic cancers. Looking at the US National Registry, so 2017 is the most updated version, but for every 100,000 women in the US, 8 new cervical cancer cases are reported, and 2 women from this group will die of that cancer. In countries with poor access to screening and prevention programs, the morbidity and mortality from cervical cancer is actually much higher. And the number of cases reported is much higher, and I'll touch on that a little bit in a while. And then in terms of the most common cause of cervical cancer is that HPV virus causes almost all cervical cancer, so 99.7%. So a little bit more in terms of epidemiology. So in Africa and Central America, so unlike where I'm saying that cervical cancer is the third most common gynecologic cancer, so there it's actually the leading cause of cancer-related mortality among women, versus like in the US where we have about 14,500 new cases and 4,300 cases, cancer-related deaths each year. So part of the reason for this huge discrepancy is that screening and prevention programs have led to about a 75% decrease in the incidence and mortality of cervical cancer over the past 50 years. And so that has contributed a huge amount to both catching the cancer much earlier or catching abnormal cells earlier so that you don't even develop cancer, and then prevention of having that. In terms of the age distribution, again, this in terms of the incidence and risk varies based on different countries, but the risk of developing cervical cancer and mortality by age 74 is 0.9% in terms of the risk, and mortality is 0.3% in the US, or in developed countries, and 1.6% and 0.9% in developing countries. So clearly a huge, the mortality is almost 3 times the amount in developing countries. And the lifetime risk of developing cervical cancer in the US was about 0.6% with a mean age of about 50 years old. So what are the risk factors for developing cervical cancer? So as I noted before, 99.7% of cases are attributed to HPV, where the subtypes 16 and 18 of the virus are present in more than 70% of the cases. So what can cause HPV that can then lead to cervical cancer. So early onset of sexual activity. So if a person is having sex at a much younger age, they're more likely to have been exposed to HPV and then to have a risk for developing cervical cancer. So when you compare someone who starts having sex at 21 or older versus someone who is 18 to 20, the risk is 1.5 times for development HPV infection. And if you were less than 18, it's 2 times that risk. So clearly, earlier age of onset, the higher risk of HPV. Again, more high-risk sexual activity, so having multiple sexual partners. The risk is 2 times with having 2 partners, 3 times with 6 or more partners, and clearly goes up the more you have. If you are having sex with a high-risk sexual partner, so even if you yourself are not having multiple partners, but you know that your partner has had multiple or other sexual partners or known HPV, that will expose you as well. If you have a history of sexually transmitted infections, that again predisposes you or puts you in a higher risk category. If you were younger when you had the first childbirth, so less than 20 years old, or multiple pregnancies, 3 or more, that again increases your risk. And people who are immunosuppressed or like having HIV. So how do you really get HPV? Essentially, you're having 2 people who are having sex, and then you can be exposed to over 100 different types of HPV infections. As I had previously noted, the HPV 16 and 18, which is covered by all the vaccines, is the most commonly responsible for causing cervical cancer. And it also has a strong proportion of causing anal cancer, vaginal cancer, and vulvar cancer as well. There are then other high-risk strains that some of the vaccines do cover as well, and I'll touch on this a little bit later, but 31, 45, and those are about 20 to 30% of the other cases of cervical cancer. There are the very low-risk strains, which are strains 6 and 11, that again are actually found in some of the vaccines, and they almost never cause cervical cancer, but they are responsible for most cases of genital warts. And then there are the very low-risk strains that basically your body clears, and the younger you are, the faster it clears up. So one thing that's important to note is that most of the HPV infections are transient. So, right, they can be cleared up. And having HPV in and of itself is not enough to develop both abnormal cervical cell growth and cancer. But the idea is when the HPV persists, from that time of initial infection to actually developing cancer, it can be about 15 years, which is why even if you are exposed to HPV at a young age, usually it will take time for that to develop into cervical cancer. Sorry. And then what about non-HPV related risk factors? So somebody who has a low socioeconomic status, which again is still in some ways predisposing you. A lot of times they might be having more sexual partners, but in this case, it's also due to limited access to healthcare and screening programs. And as that's sort of, again, that emphasis in the developing countries where they don't have access to Pap smears. Non-white race, so the highest risk of cervical cancer is in non-Hispanic Black women. Use of oral contraceptives can actually increase your risk, and the risk is related to the duration of use of oral contraceptives. So if you've been using it for more than 5 years, that tends to put your risk a little bit higher. And once you stop using birth control, their risk goes down. Cigarette smoking. So, there are 2 main types of cervical cancer, which is one is squamous cell and one is adenocarcinoma, which again is just based on the pathology. So smoking only increases the risk of squamous cell, which is the most common type of cervical cancer. And then in terms of genetic risks, unlike endometrial or ovarian cancer, where we're talking about these known genetic factors, in terms of cervical cancer, it tends to be this large variety of little mutations or sort of mistakes within the genetic makeup that can cause it, but not one specific gene. And then one thing to note in terms of a positive or not a risk factor, protective factor, is less common to be seen in somebody who's having sexual activity with circumcised males. So what are the signs and symptoms of getting cervical cancer? So in terms of early cervical cancer, it's typically asymptomatic, which is why really getting screening regularly is key, because you can catch something early and be able to cure it pretty easily. And there's a very, very high cure rate when things are caught in a very early stage. But if you do develop symptoms, the most common symptoms that we typically see are irregular or heavy vaginal bleeding, typically having bleeding after having sex, or abnormal vaginal discharge. It might have, a foul smell, be more watery than usual. So those are the main things to look for. In somebody who has very advanced disease, there are sometimes other symptoms. They may have back pain that's kind of going down their legs, or leg swelling, or they might have bowel or urinary problems, and that's usually due to a mass pushing on something and causing additional symptoms. So what are the ways that we go about screening? And most women are pretty familiar with this because you're going to your gynecologist and getting your regular Pap smears. So there are three main types of screening modalities that can be used to detect cervical cancer. The Pap smear, which, essentially you're putting in a speculum and you're taking a little swab of the cervix and then looking at that under the microscope. So you're looking at the pathology to look for cellular abnormalities. So if you're only doing a Pap smear, that should be done every 3 years. Now, and I'm going to go through the exact screening protocols, but a lot of times HPV testing is done in addition to a Pap smear. And so if they're done together, then it's done every 5 years. HPV testing alone, there's a primary HPV testing that can be done. It's not available in a lot of institutions in the US, but that would be done every 5 years. And then if you're doing a Pap smear alone and abnormalities are detected, then the reflex HPV testing will be done on those to determine further if there's any risk for cervical cancer. So what are the exact guidelines in terms of when to screen, who to screen, etc. So in an average risk woman, so that pertains to someone who doesn't have any symptoms, they have a normal immune system, and they've never had an abnormal Pap smear or cervical cancer screening. So there's a slight discrepancy in the early age group, so age 21 to 29. The U.S. Preventive Task Service Force, which kind of guides internal medicine, and actually the Gynecologic Society guidelines are very similar. They recommend that you start at age 21 and you do it with Pap smears alone for those first 10 years or up until 30 every 3 years. Versus the American Cancer Society, they actually don't recommend screening until the age of 25, and they recommend doing it along with, so like that co-testing with HPV testing, and to be doing it every 5 years. The reason that we see this discrepancy is that the American Cancer Society is included in their data people who have had HPV vaccination. So that's why they were able to increase the age to a later stage, because now it's becoming much more common for a young 11, 12-year-old to be vaccinated, and then their risk of developing HPV at such a young age is less. Part of the reason that we don't like to screen with HPV at a very young age is that there's a higher false positive with HPV infection, because there's a lot of transient infections that clear very quickly in this age group. So that's sort of why there is that difference. And prior to age 21, cervical cancer, as I had noted before, is very rare because it does take time for these infections to then develop into abnormal cell growth and subsequent cancer. All the societies are in agreement that between age 30 and 65, the three possible options that I had mentioned before of doing primary HPV testing every 5 years, doing co-testing with a Pap smear and HPV every 5 years, or a Pap smear every 3 years. So there's no reason, unless you're having abnormalities, to be needing any testing for cervical cancer more frequently than that. And then the question is, what about if you're older than 65? Do you still need screening? And the decision to stop screening really depends on your prior results. So if you've never had any abnormalities on Pap smears before, then there's no reason that we would have to do it. You would have to continue screening. And if you've had adequate screening, it also is based partially on your life expectancy and the preferences in shared decision making. And then, so that was essentially in the, as I said, the average risk population. So then the questions are, what about high risk patients or people who kind of fall outside the general category? So in high risk patients, who does that include? It really includes people who are immunosuppressed. So if you've had HIV, if you've had a kidney transplant, those people are slightly in a different category. If you've had exposure in utero, so when your mother was pregnant with you, to diethylstilbestrol, which is basically a synthetic form of estrogen that used to be prescribed to women to prevent miscarriages. Now we know that it can cause other cancers and it's never used anymore, but between the 40s and 70s, it was something that was used. So in this high-risk population, the idea, you should be starting testing 1 year within onset of sexual activity. So unlike before, we're saying age 21, this could be done at age 15, 16, etc. Primary HPV testing, so where I was saying that you don't do a Pap at all, is not approved in HIV. And in the first test that you do, you should be doing a colposcopy, which is basically looking with a microscope. Essentially, they have a device that they kind of put a dye on the cervical area, and so that they can look more closely to evaluate if there are any abnormalities done. So what if you've had a hysterectomy? So having your uterus removed, do you need to have additional screening? So in a person who's had a hysterectomy for benign reasons, maybe they had fibroids or some other reason that they took out their uterus, so no prior history of cancer or any abnormal cell growth, and they had a total hysterectomy, which means that the cervix was also removed along with the uterus, they don't need any further screening. If they had what's called a subtotal hysterectomy, so the cervix was actually kept in place, then they should continue their screening like the average or high-risk population, depending on which one category they fall into. And then there are the HPV vaccine recipients. So if you've got it, does that change your risk or your screening protocols? And at the moment, it has not changed anything. So really, even if you're fully vaccinated with the Gardasil shot or anything like that, you should still be going according to standard guidelines for Pap smears. So on this slide, I don't want you to be overwhelmed a little bit, but in terms of how do you interpret results? So essentially, when we look at a Pap smear, what we're looking for is first and foremost to make sure that it's an adequate smear, that we actually dabbed the cervix and it wasn't just some other area that was touched. So that looks for this presence or absence of this endocervical transformation zone, which is where we want to target when we get a Pap smear. And, so one result will be that there's no sign of any abnormal cells or cancer. There also could be some non-cancerous findings. So there might be some overgrowth. There could be pregnancy-associated changes, some cells that show inflammation. If you've had an IUD in place, there could be some changes, or if you had a hysterectomy, there could be changes there. But again, those aren't concerning for cancer, but they'll just be noted. There might be sign of an infection. So often there might be bacterial, fungal, viral infections that can be detected. And then the last is that there are cell abnormalities. So as I had noted before, it could be either squamous cell, which is as the most common type of cancer, but there are a lot of precursor lesions to developing that. Or they can be glandular, so adenocarcinoma, which is another type of cervical cancer that we can see. And then last thing to kind of touch on in terms of the cervical cancer, as I keep mentioning, the HPV vaccine, and for obviously it's a newer shot, so it hasn't been around for that long, and there are 3 different main forms that it comes in. And the way that these vaccines vary is as you see here, is based on the number of HPV types that they target and that they contain. So the standard Gardasil, which is the quadrivalent or the 4-target vaccine, that just targets 6 and 11. And as I had noted before, those are what's responsible for wart formation, and 16 and 18, which are responsible for about 70% of the cervical cancer. The Gardasil 9, which is probably the most commonly used one in the US, so that is, it both targets those 6, 11, 16, and 18. And it also targets these 5 additional types, 31, 33, 45, 52, and 58. So by targeting all of those, you are primarily getting all the different subtypes of HPV that is commonly causing cervical cancer. There also is a bivalent, so meaning it only targets 2, 16 and 18 is the Cervarix. But as I said, in the US, we really use the Gardasil 9. And then who gets the vaccines, or when are you supposed to do it? So the current recommendations are to start giving the vaccines usually between 11 and 12 years old, but you actually can start as early as 9 years old. So if you have somebody who is potentially going to be having sex at a really young age, you might want to consider starting them younger. And then if they didn't get vaccinated between 11 and 12, between ages 13 to 26, they can get a catch-up vaccine that is recommended. If they're 27 or older, we typically don't recommend doing the catch-up vaccine. And again, that's because they probably have had sex before. But if you have somebody who's maybe a virgin at that age or has had limited number of partners, you can consider giving them that. And then in terms of how many vaccines you get, the standard is a 2-dose vaccine protocol. So you get, and that's since anybody less than 15 years old. So there you'll get 1 shot, and then 6 to 12 months later, you'll get your 2nd shot, and then you're considered vaccinated for it. If you're above 15, then it's a 3 vaccine series. So typically you get 1 shot, 2 months later, you get your 2nd one. And then the 3rd one is given about six months after the 1st. So that's sort of the different protocols that we see in place. So switching gears a little bit. So, I think the main takeaway to really take home, I guess, from cervical cancer is that screening is really, really important. And making sure that you're getting your Pap smears every 3 to 5 years, if it's with or without HPV testing, because the earlier you can detect these cervical cancers, the better your outcome is going to be. And really striving to have something early, you don't even always, the surgical intervention is much more limited. And when the disease becomes more advanced and you might need chemo or radiation, it just becomes a much different story. So, focusing on screening and something that we know that can protect you is really important. So I noted, so we're going to switch gears a little bit to talk about ovarian cancer now. And so kind of going from there, in terms of the epidemiology and statistics related to ovarian cancer, worldwide, there are about 300,000 new cases and 185,000 cases, ovarian cancer related deaths annually. So it's clearly a more morbid of a disease in that regard. And in the US, there are about 22,000 new cases and 14,000 deaths. So the percentage of deaths to cases is much higher than what we saw in cervical cancer. About 1.3% of women will be diagnosed with cervical cancer in their lifetime, ovarian cancer in their lifetime. And unlike in cervical cancer, where I was telling you that non-Hispanic Blacks have the highest rates, so actually ovarian cancer is highest in white women. And the genetic predisposition is present in about 10% of patients with ovarian cancer. So it's one of the more highly genetic diseases. So what are the risk factors that we typically attribute ovarian cancer to? So the older you are, the higher your risk of developing ovarian cancer. If you had, so similar to endometrial, when Dr. Teplinsky was talking earlier, unopposed estrogen or prolonged exposure to estrogen can increase your risk. But so if you were very young at the age of your first period, or you had menopause at a later age, and again, this is less even from the estrogen, but the idea is that having your period regularly can cause small amount of trauma to the cells in the ovary, and that can lead to them eventually becoming cancerous. Then another risk factor, as I had noted before, is that your genetic makeup is very important. If you had one first-degree relative that causes about a 5% risk of you alone without even knowing what their genetic, risk might be. A second-degree relative has about a 3.5% risk. And if you had 2 affected relatives, that has a 7% risk. So clearly, genes are important or have a huge factor in developing ovarian cancer. If you've never been pregnant, so again, that has to do more with having your period for a longer amount of times, that again is a risk factor. If you've had endometriosis, so, it's a risk factor. Asbestos exposure can be a risk factor. And if you've had pelvic radiation for other causes, again, it can increase your risk. And then just one thing to note in terms of possible other risk factors, obesity, the data is sort of conflicting there. There's no clear one set answer that it definitely can cause it. Polycystic ovary syndrome is also inconclusive if that really contributes to a risk of ovarian cancer. And a family history of breast cancer can also contribute. And then smoking can increase the risk of mucinous ovarian cancer, but that's not a super common type that we typically see. And then what are some protective factors that can kind of mitigate your risk or limit your risk for developing ovarian cancer? So taking out your ovaries and the fallopian tubes is clearly going to almost completely eliminate your risk because you don't have any ovaries to develop cancer from. Using birth control, so if you've had more than 10 years of use, it can cause more than 50% reduction. And again, when you're using oral contraceptives, a lot of times you're not ovulating, so a lot of that trauma and other problems to the ovaries you're not going to develop. If you've had your tubes tied, that can actually decrease your risk by about 20%. Having your uterus removed can also, again, but you're not ovulating, can improve your risk. breastfeeding, and then pregnancy. And the more times you've been pregnant, the better or more protective. So as you probably can see here, a lot of these protective factors for ovarian cancer are actually the opposite for cervical cancer, where I was saying the more times you've been pregnant, the more times you might likely have HPV exposure and have had cervical cancer. So a lot of times it's a hard balance between developing one versus causing a risk for another. So unlike in cervical cancer and sort of more similar to uterine cancer, that there's no clear guidelines on who should be screened or what the screening protocols exactly are. So if you have a very high risk family history, so what does that mean? If you have a history of breast or ovarian cancer in the family, you are of Ashkenazi Jewish descent, if you have a known hereditary cancer syndrome, so if you have a BRCA1 or 2 mutation, the Lynch syndrome that Dr. Teplinsky was talking about earlier. So in those cases, you should be referred to a genetic counselor to discuss screening. And I'll talk a little bit more about what that screening would be. In a lower risk family history, so some remote cousin who's had ovarian cancer but doesn't really seem to have anyone else in the family, there's no role for screening in that person. And in an average risk woman, really with no family history, nothing else, there's no screening in an asymptomatic woman recommended. So touching a little bit in terms of on the genetic mutations and how you go about managing or screening these patients. So really the two main things to think about in ovarian cancer are the BRCA1 and BRCA2. So for BRCA1, the risk for both breast and ovarian is higher. So it's about 72% risk of breast cancer and 44% risk of ovarian. And in BRCA2, the risk of breast cancer is about 69%. And the risk of ovarian is definitely lower, and it's about 17%, but that's still relatively high. So in either type of patient, the recommendation is to remove the ovaries and fallopian tubes once your childbearing is complete. So the classic age that's recommended, if you are aware that you have one of these mutations, would be to be between age 35 and 40 years old. The BRCA2 tend to develop ovarian cancer about 8 to 10 years later than the BRCA1. So in those cases, delaying surgery to 40 to 45 years old might be considered. And, you know, if you think about it, taking out your ovaries at such a young age can be pretty traumatic because you're essentially putting yourself into menopause at a very, very young age. So if that can be delayed a little bit, but still mitigating the risk of developing ovarian cancer, then it would be recommended. And just kind of to add on to this, there's really no recommendation to take the uterus out for these cases. Sometimes if they're later, or I'm sorry, if they're older, they may end up doing it, but there's no recommendation from the setting of ovarian cancer. So if somebody elects not to take their ovaries out, then in that case, that's when surveillance would come into play, only for these select patients who have a known genetic risk for ovarian cancer. In terms of how you go about surveillance, there really is no great data and standard recommendation for screening. So it should be a conversation between the patient and their doctor in terms of what they should do. And the options that we have or that we consider doing, and again, the data here is not that great, would be to do a transvaginal ultrasound and to check a lab, which would be a tumor marker. It's called CA125. And you can begin that at age 30 or 5 to 10 years before the earliest age of ovarian cancer in the family. And that would be done every year. So again, this is not like a hard set rule in terms of screening, unlike cervical cancer, where you clearly have screening guidelines. But these are things to think about if you're deciding not to take out your ovaries when you know you have a risk. So in terms of ovarian cancer, what are the symptoms that we want to know and look out for? They're a little bit more vague. So it's not like you're having clear bleeding or something else. So bloating can be seen, having pelvic or abdominal pain, if difficulty eating or feeling full quickly. And a lot of times this is partially because in ovarian cancer, you can get a lot of ascites, which is fluid that can build up in the abdomen. So it can cause you to feel full pretty quickly. You may have some urinary symptoms, so feeling that you need to go all the time or the urge to pee, and that these symptoms tend to last. They're new and they last for more than 2 weeks and frequent in nature. Those are the things to kind of look out for again. And in terms of the workup, so again, it's typically done in somebody who has symptoms that are suggestive of ovarian cancer. They should be evaluated for a mass with a pelvic exam, so done by a gynecologist, and pelvic imaging, so that could be an ultrasound. It could be done by a CAT scan or an MRI. if something is noted, chest imaging is also then done, and that can include an X-ray or a CAT scan, and that just wants to make sure that there's no sign of disease outside of the ovaries. It's very important to make sure that you're referred, or a patient is referred to a gynecologic oncologist, because they're going to be the first step a lot of times in management. And they will need some type of biopsy, whether it be of the ovary or if there is an outside site of disease, it can be that, and getting a tumor marker at baseline as well. So with that, I'm going to end our talk, and we're going to open up to questions.
Hi, everyone. Okay, so we have a couple questions. You did answer a lot of these questions already, so we can skip over a few. I think you partially answered this one. So is HPV testing done automatically with a Pap, or does that testing need to be requested? And when does the HPV testing stop, when the Paps are no longer done? Question mark.
Yes, that's a great question. So as I had noted before, it's typically done automatically. You definitely don't need to ever request it. Sometimes the co-testing, most gynecologists in the US will be doing co-testing with HPV with a Pap. If it's not done automatically, if there are abnormalities seen on the Pap smear, then they're going to automatically add it as reflex testing. So it doesn't need to be done on top of it, because it's all done on the cervical sample. It's not like you're getting blood tests for HPV testing. And in terms of the second part of the question, when does the HPV testing stop? And the answer is yes. It's so basically the same time that you're going to be stopping any kind of cervical cancer screening, it's going to be stopping for that. So if you are 65 and you're stopping Pap smears, the HPV testing is going to be stopped as well.
Great. Okay. And you did briefly touch on breastfeeding and the delayed risk, or the minimizing risk of developing all types of cancer, or not all, but you know what I mean. So is it the longer you breastfeed, the less risk you will be for developing cervical cancer?
So the breastfeeding was more for ovarian cancer. And so I think, again, part of the reason that it's a protective factor is the same way that it is, the longer you're doing that. Oh, sorry, I don't know if they were asking the opposite, but that again, you're not getting your period for a lot of that time too. So again, it's that idea that those increase your risk for developing, or having your period for a longer period of time increases your risk for developing ovarian cancer. Yeah.
And then one more question, is there any evidence of increased ovarian cancer with those exposed to DES?
So it's not a routine risk known for that. The DES is usually associated more with both, as I was saying, with cervical, or, in general, or bladder cancers, or other things of that nature. Yeah.
Great. All right. Well, thank you so much, Dr. Teplinsky and Podolski, for this